Welcome everyone to the fifth EANO Youngster Journal Club titled Lighting Up PET Imaging in IDH-mutant glioma. I'm Antonio Fuentes Fallos, member of the EANO Youngster Committee and senior postdoc fellow, University of Cordoba, Spain. So for the new ones, I'm going to explain a little bit in which consists this EANO Youngster Journal Club. This is a 1-hour webinar discussing cutting-edge research of the recently published articles following an interdisciplinary research between basics, translational, and clinical, having lively discussion and promoting networking opportunities. So the people that make this possible is the Journal Club Working Party. That is Angelo, Tanja, Dasha, Berton, Philippe, and myself that make this possible every session. So now we are accepting youngster presenter. So if you like it and in the next one you want to be the presenter of the publication, contact me and we can work on it. Also, I would like to promote the EANO seminars 2026 for the youngster. It's going to take place in March 13-14, 2026 in Bucharest, Romania, and the application deadline is open until December 10th, 2025. So we are going to start soon. First, I would like to let you know that all the journal clubs are published and uploaded in the EANO YouTube channel. And after the presentation, the journal club presentation, we're going to have an open discussion so you can drop your question in the question and answer box that you have. Also, thanks for joining us today and looking for your feedback. So today we are gonna discuss the paper. We are gonna discuss the paper titled Prognostic Stratification of Newly Diagnosed IDH-mutant glioma by 18F fluoroethyltyrosine and 11C methionine PET, a retrospective bicentric cohort study. So we have the honor to have today Umberto Aldo, a neurosurgeon from Fatebenefratelli Hospital, Milan, Italy. Tanja Buhlmann, group leader of the translational Neuro-Oncology group in Dr. Sackenberg Institute of Neuro-Oncology, Goethe University Hospital, Frankfurt, Germany. They will be our presenters today. And also we are honored to have as a discussant Marco Riva, neurosurgeon and associate professor at Humanities University and IRCSS Humanitarian Research Hospital in Rossano, Italy. Sophie Beljusen van Satten at Erasmus MC, Rotterdam, the Netherlands. Max Mair, resident medical oncology postdoc fellow and first author of the paper at Medical University of Vienna, Austria. And Jaya Ninati, nuclear medicine fellow at Austin Health, Melbourne, Australia. I forgot to say that Sophie is a radiologist and nuclear medicine physician. So now we're going to start. Umberto, the floor is yours, so you can start presenting.
Hi, and thanks, Antonio, for the presentation, and thanks to everyone, all the EANO and all the EANO Youngster Committee and all the experts for participating for this session. I'm just a neurosurgeon, so which means I usually look at the things we want to cut, but today we will try to talk about something different and what we can actually measure. So we're gonna discuss how amino acid PETs goes beyond the anatomy, relieving the metabolic behavior of IDH-mutant gliomas that MRI alone can't capture. I will cover the conceptual framework, rationale, biomarkers, clinical relevance, and then my colleagues will drive into the analytical result and the survival data. EDH-mutant glioma are often described as better behaving tumor respect to the EDH wild type, but clinically they aren't anything but simple. And with the new WHO classification, prognosis still relies on age, grade, and extent of regression, variable that cannot really capture the underlying tumor biology. So typically, MRI gives us structure, not the metabolism, and it can miss regions of active disease, especially in non-enhancing glioma. There are some functional images, in particular amino acids PET, comes in to show us the biology behind the anatomy. Amino acid PETs goes one step beyond the MRI by showing us as tumor metabolism rather than just a structure. The tracer used can be fed or met, which enter the tumor cell through the LAT amino acid transporter, which are overexpressed in glioma. Importantly, this uptake doesn't depend on blood-brain barrier disruption, so PET can reveal also the non-enhancing tumor regions that the MRI might underestimate. This has a very important clinical meaning. Indeed, PET helps us to target biopsy, plan surgery, radiotherapy, treatment monitoring, treatment response, and even get a sense of prognosis based on the metabolic activities. Before looking at the result, let's quickly clarify, because it's a transversal meeting and some different professionalism in this session. So before looking at the result, let's quickly clarify what's the key PET parameter mean. The TBR max is a tumor to background ratio max. Is a single hottest voxel. It reflects the peak of metabolic activity of the tumor. The TPR mean average is a tumor to background ratio mean. It is the average uptake across the whole tumor volume, so it reflects the global metabolism and is less affected by noise. Finally, the metabolic volume measures how large the metabolic activity in the region is. Typically is defined as the area within the TBR above 1.6. Together, these parameters describe both the intensity and the extent of tumor metabolism. For a long time, PET evaluation in glioma was mainly quantitative. We looked at the bright spots, so it was hard to compare across center. It was difficult to standardize. So the Red PET working group changed these elements, introducing in 2024 the PET-EANO criteria. This criteria was defined measurable metabolic disease based on quantitative threshold, in particular a TBR max above 1.6 and a metabolic volume larger than 0.5 microliters. This standardization allows PET results to be reproducible and comparable across institutions, enabling integration into treatment response and standardize them in a clinical trial setting. This studying it's one of the first to fully apply this standardized approach on EDH-mutant glioma. So the aim, the main study aim, based on this rationale, these authors designed a study to evaluate whether the quantitative PET parameters could predict outcome in new diagnosed EDH-mutant glioma. They specifically looked at three metrics defined by PET-EANO criteria, which is the TBR max and TBR mean and the PET volume. And they tested the association with time to the next intervention, the TTI, and the overall survival. The hypotheses were that higher uptake intensity or larger metabolic volume would identify patients with an early recurrence or shorter survival, And this relationship made different between astrocytoma and oligodendroglioma. Clinically, amino acid PET gives us a layer of metabolic information that MRI simply can't prove. By quantifying tumor metabolism, PET helps to stratify patients according to risk. Those with high uptake tend to progress earlier and might benefit from an early adjuvant therapy, while those with low uptake could safely undergo a watch and wait approach. This composite is perfectly fits with the Indigo trial and introduction of the TTNI as relevant endpoint in low-grade glioma. So PET is not just a diagnostic tool, it's becoming a decision-making tool, including how and when we treat our patient. Of course, there are several limitations to keep in mind. It was retrospective single-center study and mixed FET and PET and MET tracer, which aren't completely equivalent, of course. PET uptake was also heterogeneously. Not all the IDH-mutant glioma are strong PET avid. And even though we have a cutoff from PET-EANO, we don't yet know if they apply across all the tumor grades. All the tumor grades or center. Clinically, we still lack, of course, prospective data to show how PET should directly influence treatment decision. So we have seen the conceptual framework, how PET can quantify tumor metabolism and potentially predict outcome through the parameters like TBR max, TBR mean, and PET volume. The next step is to see whether the data support this hypothesis, whether this number actually correlate with patient's outcome. And that's why, and that's what my colleagues, Tanja, will now walk us through into the analytical session.
Yes. So, sorry. Okay. Perfect. Can you just quickly tell me if you see my screen here? Yes. Okay, perfect. Yeah, thank you very much, Umberto, and hello to the audience. My name is Tanja Buhlmann. I'm molecular cancer biologist from Frankfurt, Germany. And in the project, in total, 457 patients were evaluated and all were diagnosed with an IDH-mutant glioma. Among them, 251 were diagnosed with an astrocytoma and 206 with an oligodendroglioma. All patients underwent amino acid PET imaging, and these image data sets were reassessed according to latest PET-EANO criteria to ensure standardized and comparable evaluation across both centers. And using the PET-EANO criteria, they were able to subdivide the cohort into 3 categories. So the measurable disease category, comprising roughly 70% of the patient, the non-measurable disease category comprising roughly 15%, and the no measurable disease category defining around 16%. For the further analysis, the non-measurable and no measurable disease groups were combined into one category, since both represent tumors without clearly quantifiable uptake. Because oligodendrogliomas showed significantly less PET uptake and larger PET volumes compared to the astrocytomas, all subsequent analyses were performed separately for both histological subtypes. It was then analyzed how the quantitative PET parameters such as TBR max, TBR mean, and PET volume were associated with the clinical outcome measured as time to next intervention, or TTNI. So the first analysis was TTNI in the astrocytoma cohort divided by measurable versus no and non-measurable disease. The results are visualized using a Kaplan-Meier curve, which is the classical way you probably all know to display survival or time to an event analysis. For those of you who do not routinely work with Kaplan-Meier plots, the y-axis shows the percentage of patients who have not yet experienced the event, in this case, who have not yet required another intervention. And on the x-axis is shown the time in months. Over the time, as more patients need a new treatment, the curve drops downwards. For the first example here, I will take a bit more time so everyone can get familiar with reading these plots. Here we see the astrocytoma group comprises 229 patients with an astrocytoma, of which 121 had a measurable disease, and a total of 108 patients was grouped in the non and no measurable disease group. At time 0, where not yet any patient had to go initial intervention, both groups were set to 100% or here to 1.0. And over the course of follow-up, the percentage of patients without an additional intervention decreases in both groups, but you can see clearly faster it drops in the measurable disease group. In other words, astrocytoma patients with measurable metabolic activity on PET reach the next intervention significantly sooner than the non or no measurable disease group. And this indicates that higher PET activity likely reflects maybe more aggressive or faster growing tumor. Yes. Next, the individual PET parameters were analyzed in relation to the time to next intervention. To do this, the authors used bootstrap analysis to define optimal cutoff criteria for the 3 parameters. So for the TBR max, it's 1.93, for TBR mean it's 1.94, and the PET volume is 2.3 milliliters. And the patients were divided into high and low groups of each parameter, and again compared using the Kaplan-Meier curve. As you can see, higher PET uptake or larger PET volumes all consistently were associated with a shorter time to the next intervention here, indicated again in the yellow curve. This indicates that the metabolic tumor activity provides strong prognostic information in IDH-mutant astrocytomas. But you remember that the total cohort also included oligodendroglioma patients, so the question is how predictive is PET imaging for those tumors? And here we see the same type of analysis as before, now applied for the 189 oligodendroglioma patients. Among them, 168 showed the measurable disease subtype, while 21 had no or non-measurable disease. However, in contrast to the astrocytoma cohort, there was no significant difference in the TTNI between these 2 groups, meaning that the presence or absence of measurable PET activity did not predict how soon the next intervention was needed. So in the oligodendroglioma subgroup, PET measurable disease did not carry any prognostic value. Here we see the same Kaplan-Meier curve for the 3 quantitative PET parameters in oligodendroglioma, and again, bootstrap analysis to do the defined optimal cutoff criteria for TBR max and TBR mean. The curves largely overlap, indicating that tumor uptake intensity alone does not influence the TTNI. However, when looking at PET volume, there's a visible separation of the 2 curves. So patients with a larger metabolic activity have shorter TTNI, meaning that require another treatment sooner. And this suggests that while uptake intensity measured by the TBR values is not prognostic, the overall metabolic tumor burden may still carry some prognostic relevance in the oligodendroglioma cohort. So far, we've seen that PET imaging can provide prognostic information, particularly at astrocytoma. But before we go deeper, let's remind ourselves how the current WHO classification already defines the major features of the tumors. Here on the left, you see the molecular classification flowchart. So adult type diffuse gliomas are firstly separated based on the IDH mutation, and secondly by the 1p19q co-deletion status, resulting in the oligodendroglioma or astrocytoma subtype. And then within each entity, WHO grade 2 and 3 is determined mainly by histopathological features, for example, metabolic activity and necrosis. And clinically, as shown on the right side, this grading has direct therapeutic implications. So grade 2 tumors, especially when completely resected, are often managed by active surveillance. However, grade 3 tumors, in contrast, typically receive adjuvant radio and chemotherapy right away. So WHO grades already define much of the expected tumor behavior and the treatment pathway that follows. So the key question now is, can PET imaging provide additional prognostic information beyond what we already know from the WHO grading? And this combined analysis combines the WHO grade and the PET parameters to explore the prognostic relation. On left, again, we see the ASST tumor cohort. On the right, we see the oligodendroglioma cohort. The ASST tumor cohort is divided by the TBR mean and the WHO grade, and the oligodendroglioma cohort by the PET volume and the WHO grade. And what becomes clear is that the PET parameters dominate the separation of the curves. So within the same PET parameter, for example, the TBR mean, high TBR mean, the grading does not further separate the patient outcome, the two groups. And the same pattern we can see in the oligodendroglioma cohort. So overall, PET parameters show a stronger prognostic implication than the WHO grade, suggesting that the metabolic activity on PET may reflect tumor aggressiveness even more accurately than the histology alone. And to summarize, the study shows several key findings. First, using EANO criteria, about 70% of the patients had measurable metabolic disease, and this measurable uptake was prognostic at astrocytoma, but not in oligodendroglioma. Second, when looking at quantitative PET parameters in astrocytoma, high-value TBR max, TBR mean, and PET volume were all associated with a shorter time to next intervention, while in oligodendrogliomas, only PET volume showed a relevant association. And third, when combining PET data with WHO grade, they saw that PET parameters can further refine prognosis within the same grade. And with this, I would like to thank you all for listening so carefully. And in the following discussion, we will address now additional aspects of the study that I did not cover for sake of time. And of course, we'll discuss the clinical implication of this work. Let's stop sharing.
Thank you, Tanja and Umberto, for presenting this well-explained presentation. And we are going to open the discussion. Just a reminder, drop your question in the question and answer box, not in the chat. And I don't know if some of the presenters want to... Oh, thank you, Natalie, to join.
Hi.
So we have another discussion in the last minute, Natalie Albert, author of the paper. And Umberto, Tanja, do you want to break the ice for the discussion and drop a question?
Yeah, I have some questions, one in particular to our clinical colleagues. We have seen how PET can help us in modifying time to the next intervention. So in non-enhancing gliomas, could the PET uptake justify an earlier surgery instead of just an observation?
So it's open to answer, Sophie.
Yes. Yes, so as a radiologist and nuclear medicine physician, I do see tumors that are negative for enhancement on MRI, yet do show uptake on the PET. And I think these are clear indications that the PET adds to the information of initiating treatment. I'm not sure if this is a direct conclusion that we can obtain from the manuscript that we discussed today, but I do think it's helpful in clinical practice, yes.
If I can add my contribution as a neurosurgeon, I think this is this paper that you just introduced and we all read add further evidence of the usefulness of PET in the initial workup of gliomas in general. So from this previously known lower grade to also to higher grade, also because we have to consider that we sometimes, several times we saw that we have that the PET scan do not perfectly overlap with the MR visible abnormal margins. So I feel that also as a neurosurgeon, to target either with biopsy or when open resection is much more indicated, and we have evidence that surgery can be indicated in non-enhancing gliomas for its therapeutic effect. Having PET is a powerful way to really personalize treatment, both in terms of resection, tissue sampling, and time to intervention. Or time to surgery, time to then stratify adjuvant therapies. So I really feel that PET provides an added value to the diagnosis, presumptive diagnosis, working up diagnosis, and then therapy. And one of the main gain we have in surgery, as one is used to say, tissue is the issue. If we want to sample the proper tissue in the OR, especially also in an open resection, microsurgical resection, PEN can be beneficial, especially in those non-enhancing gliomas that are the majority of the previously called lower grade gliomas. And since we are dealing with younger adults patient with an expected longer overall survival, this is, I think, crucial to really maximize the resection, always sparing relevant neurological function. That is the other main issue as us for surgeons.
And I think in light to this, the publication of the RANO 1.0 for PET imaging is a super important step, because this provides clinicians and researchers a first guideline to standardize what we do with the images. So I think this paper is also a good example of how you apply the RANO 1.0 criteria for the first time to analyze subgroups and to compare data with each other. And I think this paper really nicely shows that you finally now have some criteria that you can use as a common language among institutes or researchers.
Well, we have a question from the audience. Were there difference in methionine and fat PET in TTNI? Max, there's a question for you.
Yeah, thanks for this question, which was actually also one of the reviewer questions. So just to give some insights. But actually, on one hand, we had very few methionine PETs in there. So it was just a small share of these 450 patients that we have included there. But in analysis that we did so in this cohort, we couldn't find any significant differences there, which is also what we believe in clinical routine. So there is no point for us to believe that fat PET is superior to methionine PET or vice versa. So, and our data nicely showed that also in terms of prognostication, that there are no differences between those two tracers.
I think overall it's also good to comment on the accuracy of methionine PET and FET PET. So the accuracy is comparable. But the big advantage of FET is that it's labeled with F18. So it's a radionuclide that has 110 minutes half-life. So for the clinical routine, it's much more feasible to use FET. And also with one production, with one radionuclide production and labeling of the amino acid tracer, you can really scan a lot of patients on the same day, while with methionine, you have only 20 minutes due to the labeling with C20 and that's C11, and therefore the half-life is much shorter, and you can only image 1 or 2 patients with one production. So like from a logistical point of view, it's a big advantage to use FET, and it's the most widely used tracer in Europe.
One of the questions that arose to me when I was reading about the cohorts with methionine and FET was, is there a historical difference? So for instance, were the methionine patients scanned in the earlier days with potentially also another PET scanner, and the FET patients from a later period, or was that not the case?
Do you know the answer, Max? Because I think all methionine patients came from Vienna, and I remember that I had a discussion with the head of nuclear medicine department there, because I was wondering why he was using methionine, but I think it was also a logistical reason. However, in a different way, that he said that in his radio pharmaceutical unit, all the machines were used for other F18 labeling, and that's why he said it's easier for him to produce methionine. But I don't know, Max, if you have any other comments on that.
Yeah, it's as you said. I mean, the patients who underwent methionine PET at our institution are patients of some earlier days. So nowadays we are also using FET more. So we just use methionine in very rare circumstances, which also has logistical reasons then. But yeah, so there might be a tendency to methionine being used in earlier days in Vienna. Yeah, but as said, there haven't been any significant differences also in terms of years then, yeah.
Yeah, I think this is a learning point for the people who are not from the field of radiology or nuclear medicine, that when you're reading a manuscript on imaging, it's always important to consider the time frame in which it was written, because there's such a rapid technical evolution going on that the machines are improving a lot. So each 5-year time frame, I think, is already something to be aware of. Potential differences there.
Cool. I think that people is like starting asking question. So Rasha Elatar, can PET say the grade of glioma, for example, GBM?
What was the question? Sorry.
Can PET say the grade of a glioma?
Well, the PET uptake intensity certainly correlates with the tumor grade. So what you typically see in IDH-mutant gliomas is that you have higher uptake intensities in grade 4 astrocytomas than in grade 2 astrocytomas. And also the percentage of PET positivity increases. For example, in grade 2 astrocytomas, you see about 60% being FET negative. In grade 3 astrocytomas, 40%. And in grade 4, it's more than 90% being positive on the PET. Right, so there's certainly a correlation with the tumor grade. However, if you try to predict the tumor grade without knowing if it's an astrocytoma, oligodendroglioma, or glioblastoma, it's starting to be difficult because oligodendrogliomas are characterized by such a high uptake intensity. So you may have a high intense uptake with a TBR max, for example, of whatever, 4.0, 5.0, and you may think, okay, this must correspond to a grade 4 glioma. However, the oligodendrogliomas can look exactly the same. So by seeing the PET image only, you will not be able to predict the tumor grade. But if you start to compare it with the MRI and you see, for example, okay, it has whatever, no contrast enhancement, calcifications, it looks like an oligodendroglioma, so that you have already an estimation, then it is possible to estimate the tumor grade. However, as you also saw in the paper, the overlaps are really large between grade 2 and grade 3 gliomas. However, there we have also to say, we don't know who is right. Is the neuropathologist right with his binary tumor classification, or is the nuclear medicine physician even better? If we look at the correlation with the outcome, we have to say we are probably better than the neuropathologists. So yeah, there's a correlation, but it's not one-to-one the same thing that we're seeing.
Also, we have another question from Ajay Mohan. This direct to Professor Albert, but I think not all the clinicians here can answer this. What do you think about the use of TC methionine in GBM patient given the constraints of the cyclotron and half-life or the radionuclides? What do you think? Like, it's necessary to do the PET for the GBM patients, or just like limited to the IDH mutant?
Oh no, I think it's very valuable also in glioblastoma patients. I think it may have a different value there. So for glioblastoma patients, for example, I see a lot of informative value in the delineation of the tumor extent, because very often you see contrast enhancement on MRI, which represents the target for tumor resection, which represents the target for radiotherapy planning. However, we all know that we do have non-enhancing tumor parts in glioblastoma, and it would be extremely helpful to know how large the tumor is in reality in order to plan local treatments, right? So there, FET-PET is very, very valuable because it can delineate all the non-enhancing tumor parts much better. So if you want to resect a glioblastoma, it is useful to have the preoperative PET scan, but maybe the neurosurgeons here can comment on that if they use it already in clinical routine or not. But there it can really very reliably depict the viable tumor tissue. It has a positive predictive value of about 98%. So we have not published that yet. So maybe we're going to have another session somewhere after publication of that paper. But it's very interesting to see that the positive predictive value is that high. So if you see positivity on FET-PET in a patient with glioblastoma, you can be nearly sure that the positive parts are vital tumor tissue. So this is one part, and then of course also for response assessment, particularly after irradiation, where you don't know if it's treatment-related changes or progressive tumor tissue. There, it is extremely helpful to have additional PET images, but not only at one time point when the clinician has the question already if it's tumor tissue or reactive changes. But I would always favor to have longitudinal images so that we can really do the PET-RANO assessment and say, is it progressive disease? Is it partial response? What is it?
Cool. Do I want to add something on it? Go to the next question. We have another question for Eduardo Pronello. We know that this type of tumor have a lot of seizures across time. Is TBR altered by active seizures? Or let's go, Sophie. I think that you know the answer.
Well, we do see some other things related to uptake other than only tumor activity. So seizures is one infection. We see sometimes radiation effects should be taken into account. So I think these are things that we still need to learn from all the data that is becoming available. I don't know, Nathalie, do you have any additions to that?
Regarding this last question, if I may add something, we had a very little paper, a very surgical one, where we analyzed the epileptological outcome regarding gliomas in the temporal lobe, that, as we know, is the one that's affected the most epileptogenic part of the area. And we found that the co-localization of the tumor and the hypermetabolic spot, especially in the temporomesial area, so close to the hippocampus region, is a predictor of a poor epileptological outcome. So this is not to say to be conclusive on that, but I think that also if we dig into the data, especially looking at the epileptological outcome with the scales, we can also find an added value. And this will be even more relevant for the neurosurgical community that is, of course, always aimed to maximal, supramaximal resection for both the prognosis, but also for the functional outcome. And we all know as uncontrolled seizures, beyond being a sign of progression in the story of those patients, can be a debilitating history issue in the life of those patients. And if we claim to improve also the quality of life, this can be a focus to be taken into consideration. But definitely the PET scan preoperatively also can provide some, is not influenced by the seizures, but can tell you, probably because that is the more aggressive spot of the tumor, where to focus your resection also for an epileptological outcome, not just for the oncological aims. I don't know if colleagues in other centers have similar opinion or view or clinical surgical feeling.
Cool. So let's move to the next one from Dasha Fedruskova, that is a member of the journal club working in Paris. Does the difference in uptake intensity between astrocytoma and oligodendroglioma reflect a biological underlying mechanism? Max?
I can further
Yes.
comment
Oh,
on that.
great.
So I think this is a very good and interesting question. I think the main strength of the paper we discussed today is that authors perform subgroup analysis. And so they analyzed the IDH-mutant astrocytomas and oligodendrogliomas separately. We know that they're very different disease entities from a histopathological as well as molecular point of view. And this is very well reflected by different uptake patterns on amino acid PET imaging. So for example, as we have just seen, oligodendrogliomas tend to have very high and homogeneous amino acid uptake on PET imaging. And this is somehow counterintuitive, because we know that they are among adult type diffuse gliomas, the ones with the relatively better prognosis. And also as nuclear medicine physician, we tend to associate increased amino acid uptake to disease aggressiveness. But we know that that is not the case for oligodendrogliomas, as it has emerged also from the paper we discussed today, where the uptake intensity wasn't directly associated to worse patient outcomes or prognosis. So I think for oligodendrogliomas, oligodendrogliomas actually are a little bit of a separate question. We don't actually fully understand the reason why they have such a high uptake, but some hypothesize that might be due to there being very hypercellular tumors and with very high intrinsic expression of amino acid transporters on their cell membrane. While for IDH-mutant astrocytomas, the history is very different, because we have seen from this paper, but also other previous investigations, that the intensity of uptake is strongly associated to worse outcomes and also worse patient prognosis. IDH-mutant astrocytomas tend to have a much more heterogeneous uptake, and as Natalie just said, in up to 50% of cases, they can be negative on amino acid PET. So I think one message I think it's really important to give today is that subgroup analyses are really important to be performed when conducting studies on amino acid PET imaging in IDH-mutant gliomas, which is something we don't actually see happening too much nowadays. Still review many papers where distinctions and subgroup analyses are not made. And this really prevents, and in my opinion, this really prevents to have and obtain meaningful results.
Yeah, I absolutely agree, Gaia. So it is essential to make the subgroup analysis and not to put them all into one group, because then the result would probably be that nothing correlates with survival. And to come back to the question, what's the basis? How can we explain the differences in uptake intensity? We have really no idea, and I'm now spoiling a lot of unpublished data today, so I hope that's fine. Because the Vienna group with Matthias Preußer and Jan Werner, who is of course in Cologne, but who did a clinical research fellowship in Vienna last year. They asked exactly that question and said, okay, let's just look into the oligodendroglioma that have this typical high uptake intensity, and analyze the tissue samples and try to assess the expression of the LAT1, so the L-amino acid transporter, which has always been discussed as the main transporter that is responsible for the FET uptake. And so what was our expectation? The expectation was, of course, that the LAT expression should be much higher in oligodendrogliomas compared to astrocytomas. But the funny thing was that this was not the case, and that we didn't even see high LAT expression on the tumor cells, or I'm saying we, but it was the Werner group, but I had a look at the data as well because I couldn't believe it. Yeah, so at the moment, it's really under discussion which transporters are indeed responsible for the uptake of FET. So although we have discussed for 2 decades that it's the L-amino acid transporter, and you find it in all publications and all papers, because we're always citing probably the same first paper that has investigated that in not even in human data and not even in murine data, but in cell cultures. Probably it's not even the responsible transporter for FET. But at the end, I have to be very honest, as long as I see the tumor cells, I'm happy. So although I don't know yet which transporter is responsible.
Yeah, this is a super interesting discussion, I think, and it also shows the important interplay between the neurosurgeons who take the biopsy in the relevant areas of FET uptake or MRI characteristics uptake, then the preclinical or pathology people who define the tumor areas, and then also the oncologists who determine to treat or not to treat. And I think the discussion you just raised, Gaia, very interesting, does connect to a topic which is also very hot in nuclear medicine at the moment, the theranostics, of course, because in the end, we do need to understand what the mechanism is of the uptake if we want to translate it to therapy, of course. I mean, in that moment, we do need to know which is the transporter, how does it work, because we do want to get the radioactivity at the right place through the right mechanisms.
Also, moving to the next question, Ana de la Rosa, report higher PET uptake in oligodendrogliomas versus astrocytomas. We were talking. Could this be useful for early diagnosis regarding the PET volume? And also, there is a second question. Did patient undergoing pre and post-surgery PET scan have complete resection? And if not, did you notice any changes in PET parameters compared to before surgery?
Well, maybe for the second part of the question, yes, we had some patients in our cohort who underwent pre and post-surgery amino acid PET. It was a small number, but still not all of them had complete resections. So some of them had just subtotal resections. And of course, if you take part of the tumor out, you remove PET positive tumor volume. And that's also the reason neurosurgeons love to do a PET before surgery, because then you have more idea on where the most malignant part of the tumor is, as we have already discussed before. So yeah, of course, there are differences, although we haven't looked into that in more detail, because the main aim of our study was to see whether this prognostic impact that amino acid PET has also holds true in post-operative PET. So whether it really matters what's still in the patient in terms of PET-positive tumor. I'm not so sure whether I understand the first part of the question. So of course, you do PET in patients where you have a strong clinical suspicion of a low-grade glioma. So early diagnosis is not really an indication for PET in these kinds of patients. But still, with the higher uptake you have in oligodendrogliomas, you see them earlier than in astrocytomas, because in astrocytomas, as we have already heard before, there's also a strong correlation with tumor grade. But still, in oligodendroglioma, you also see lower grade, so just grade 2 tumors with high uptake, which is not so strongly the case in astrocytomas.
Oh, thank you. So next one, we'll expect imaging with TC999 methionine be of any value in a clinical management?
I think technetium is being called, or not, Natalie?
Yeah, I'm super surprised to hear the question with technetium imaging. So I'm not aware of any technetium amino acid tracer.
No. Let's go to move to the next one.
Well, anything.
I'm not an expert, so.
Your trainer.
Cool. Will a PET tracer targeting mutant IDH able to differentiate between astrocytoma and oligodendroglioma? You already answered this question. Sorry, there is a lot of questions right now on the chat, and
That's
I have
good.
time
That's
to
good.
do everything. Where does FIPI imaging stand?
Pardon?
Where does FIPI imaging stand? Yep.
Yeah, very good question. So FAP imaging is directed towards the fibroblast activation protein, so something that is associated with fibrosis. And there are lots of different tumor types where you see high FAP expression in the tumor microenvironment, and therefore FAP is of high interest now in the oncological community, because many tumors that you usually see lighting up in FDG PET are also lighting up in FAPI PET, and sometimes even better. And what's so special about FAP in comparison to FDG? Well, FDG, you can use that only for PET imaging, but not for theranostics, because just imagine you try to label glucose, which is really being eaten by all kinds of healthy cells, and then you are really irradiating everything in the body, and particularly the brain. That would be terrible, right? But for FAPI, you could also label the radiopharmaceutical with a therapeutic radionuclide to do a theranostic approach. So in general, FAPI is something which is of high interest at the moment in the nuclear medicine community. However, for brain tumors, I don't see a lot of potential, to be very honest, because in different kinds of gliomas and in meningiomas, we've also analyzed that in meningiomas, so Max can maybe comment on that. We do see some expression, but it's not a super high expression, and particularly in gliomas, it's not very high, only in the subtypes of gliosarcoma. So if you have a gliosarcoma, then you will see high FAP expression and high uptake intensity, so that may be of interest, but how many gliosarcomas do we have in clinical routine? They are very rare, so that's why I think there's not so much potential for FAPI in primary brain tumors. The situation may be different for brain metastases, which also typically show FAP expression or have a lot or can have a lot of fibrosis in the tumor microenvironment. So for brain metastasis, I think it may be of interest and should be evaluated in the future.
Oh, thank you. And we have here another question regarding boracidinib. Like grade 2 astrocytoma and a PET positive, would you do boracidinib for radiotherapy, chemotherapy, or which other factor would you consider to the patient management?
Yeah, interesting and also very complex questions. So I take this one as a medical oncologist. So actually, we don't know right now, right? So of course, the parameters we're taking into account right now is WHO grade, of course, but there's lots of data out there that tell us that there's inter and intra-observer variability. So if you show the same specimen to two neuropathologists, one of those will say it's a grade 2 and the other one will say it's a grade 3 astrocytoma. So this is a problem in clinical routine. Extent of resection matters, but what also matters is how symptomatic is the patient. So does the patient have any symptoms, tumor-related, after surgery? And then, of course, our data suggests that PET might also have an impact there. So if you have a tumor with a high TBR max, for example, in astrocytoma, that's something you could take into account. But of course, it's a retrospective study. So of course, you also have biases in there, and it's interesting data, but you have to validate it prospectively. But still, I'm very convinced that PET will increasingly have a value in our clinical decisions, especially in challenging situations as we have them in IDH-mutant gliomas. So it's young patients, and of course also treatment intensity matters, as these are patients that have relatively long survival times. So they will experience treatment-related side effects. So yeah.
And does you have a question related, Max, that you will take TBR mean or PET volume to be taken alone for assessment in clinical trial in glioma?
Well, I think it's an important thing to consider in future clinical trials. So all clinical trials we have right now, or most of them so far, just focused on MRI and also MRI-based measurable disease according to RANO criteria. But of course, we will get much more data if we include PET imaging there. We will get much more data if we include PET-based response assessment there. So yes, I'm convinced that PET will matter as an eligibility criterion also in clinical trials, but also in terms of response assessment, particularly as we have now PET-based response assessment criteria.
That's also, maybe just to add, that's why we also added PET as an optional imaging method in the Vigor trial. So if your sites are participating in the Vigor trial, please try to make sure to also perform PET images in your patients. I think that will be extremely valuable to generate some data there in the clinical trial context.
Oh, thank you. So we are finishing up. I'm so happy that we are having a lot of questions here. Just a quick question. Will there be a theranostic tracer for brain cancers? Who is willing to answer? Sophie?
Well, let's end positive. One day, yes. I think many people in the consortia that we work in are working very hard to research this topic. And I think if you see what progress has been made in the last 5 years already, I'm very positive about the next 5 years.
Cool, thank you. So we are 1 minute to finish. I want to say some closing remarks, like thank you all to be here this afternoon and contribute like this educational and and really informative journal club. Thank you all, and see you in the next one.
Thanks a lot. Bye
Bye.
bye.
Thank you. Bye bye.